Thank you very much. It's wonderful to be here. I want to certainly thank the organizing committee for inviting me to speak today. And I look forward to talking with all of you over the course of the next 2 days of the conference. I have no disclosures or conflicts of interest to report. And before I get started in my presentation, I thought I'd just share a little bit about myself and, why am I a part of Exercise as Medicine? And this is a collage of pictures that I created for you that is kind of my physical activity journey, which really started as a competitive athlete. I was a three-sport athlete in high school. I played volleyball for the University of Minnesota when I was in college. And since then, I've moved from Minnesota to Utah, and I live in this beautiful place. I'll show you a few pictures in a minute. And I do a lot of physical activity outdoors. I hike with my friends, my family, my dog. I've inspired my children, who are both rock climbers. The picture in the upper right-hand corner is me on a walking desk. And I was an early adopter of the walking desk. I've actually had one for 17 years. That's a story in and of itself. But that desk that I have right there is called a Trek desk. And I was one of 4 people in the United States to get one when they first came out. One of the pictures in the middle is my mom. My mom's 88 years old, and there she is in the gym, doing some strength training because I think it was her daughter who said, Mom, active, healthy aging includes doing some strength training. So there she is. And there's me on crutches. One of my sayings as a sports medicine doctor is, an injury is always an opportunity to work another part of your body. In this case, I was recovering from a broken pelvis, having taken a bad tumble skiing. But boy, you can see that big smile on my face because that was one of my first forays outside on crutches. And it felt so good to actually be walking and not sitting. And last but not least, in that lower right-hand corner is me outside of my clinic looking outward. Because, I believe and have experienced that people do not get well and stay well in the doctor's office, right? They get well and stay well where they live, learn, work, play, and pray, right? And we should be integrating physical activity into all of those environments so that people can live their healthiest lives possible. So, I live in Utah. It's that red state over there in the western part of the United States. I moved there 30 years ago from Minnesota, and it is a beautiful place to live. Part of the reason I moved there was because it has these beautiful mountains, and I've been skiing since I was 8 years old. And we like to say that in Utah we have the greatest snow on earth. At least that's what our license plate says. But Utah is an interesting state. We have mountains and snow and cold in the north, but in the south, we have a beautiful desert, absolutely beautiful. And in fact, I think the desert is my most favorite place to be in Utah. But I thought I'd share this. I took this picture hiking not far from my house. I have the pleasure of living at about 6,000 feet, so in the mountains. And this is, I can walk out my front door and I can be on a trail in 5 minutes. And I took this picture on a beautiful fall day when I was hiking at sunset. And then lastly, I want to just take this opportunity to invite all of you to come to the ACSM annual meeting, which will be held in beautiful Salt Lake City, Utah, next May and June. And so you can see the dates there. It's from May 26th and through the end of through May 29th, and we haven't been in Salt Lake City for, many years, more than 30 years. So it'll be a fabulous meeting, and I invite all of you to come. All right. Well, without further delay, this is what I'm going to talk about this morning. I thought I'd share a few words on the Exercise as Medicine initiative. I'm sure it's very familiar to most of you, but perhaps not all. And then I was really asked to talk about my experience leading the integration of Exercise as Medicine at Intermountain Healthcare, which is a healthcare system I worked at for 13 years. I left that role a couple of years ago But during that time, I worked with many colleagues to develop and integrate a physical activity vital sign into the electronic health record, into clinical workflow. I'll talk a lot about it, both the implementation of that as well as some research that we have continued to do to actually show that integrating physical activity into healthcare can make a difference in people's lives. And then I thought I'd finish up with some key next steps in the United States that we're doing to integrate physical activity into healthcare, which I hope inspires some thoughts and ideas from all of you in your countries. So at Exercise is Medicine, our vision is to make physical activity assessment and promotion, a standard in clinical care. Connecting healthcare with evidence-based physical activity resources for people everywhere and of all abilities. And, I could spend the entire talk just talking about all of what we're doing within Exercise is Medicine. I'm going to try and summarize it in just a few slides here. But the initiative was actually launched back in 2007. It was the presidential project of Dr. Bob Salas. He and I are close friends and partners in this work, and he and I have been working on this together since that time. We have the European national centers represented here at this Congress, and we have more than 30 Exercise is Medicine national centers worldwide. Exercise is Medicine on Campus was launched, also several years ago. It has continued to grow and grow, and really is where we help to develop and inspire, not only the exercise professionals of the future, but research scientists and clinicians. I think it's true in Europe as it is in the United States, but exercise science is the #1 pre-medical degree. So I'm so inspired that people who are now going into medical school have this foundation that around exercise science, exercise physiology, that informs them and inspires them to continue that when they get into medical school. Exercise is Medicine is led by a global governance board for which I am the current chair, and we have 5 additional committees that are in clinical practice, pediatrics, older adult, our Exercise is Medicine on Campus, and then a group focused on underserved and community health. Moving Through Cancer was an initiative that was started by Dr. Katie Schmitz. She is an exercise physiologist in Pennsylvania, and she has been an absolute force in exercise oncology. And I know many of our European EIM national centers have a focus in exercise oncology and are certainly connected with Katie and her work and leadership. New to Exercise is Medicine, and you'll hear more about this tomorrow from Dr. Mark Stoutenberg, is Exercise is Medicine Active Aging. And this is a new initiative within Exercise is Medicine that has really been in development over the course of the last year. We have a very esteemed colleague, Paige Dennison, who is helping to lead that work. We announced it. It had its coming out party at the ACSM annual meeting in Atlanta. And like I said, Mark will share more about this tomorrow. The EIM Emerging Leaders Program in both the US and Europe is critical for the success of Exercise is Medicine, because without creating and supporting the next generation of leaders, this will not be a sustainable initiative. So we're very proud of our emerging leaders in the US and in Europe, and it's been so wonderful to meet many of you yesterday at our meeting and to continue to have conversations over the course of this conference. I'll talk a little bit more about a partnership that the Exercise is Medicine has with the U.S. Physical Activity Alliance as well as other organizations. I skipped over the EIM Research Learning Collaborative, which Dr. Stoutenberg leads, which is really around creating a community of researchers to share ideas so that we can amplify the work that we're doing in our various centers and countries. We have a very robust educational program that is really in partnership with the American College of Sports Medicine for both exercise professionals and healthcare providers. And more recently, we now have dedicated exercise as medicine content in a number of ACSM journals, which are listed there, as well as dedicated sponsorship partners. So you can see this is a lot going on. There's just a handful of us who are leading all these efforts, my tired colleague over there. But we're really proud of this work, that has been developed over the course of the last 18 years. So I'm a little curious, how many of you are familiar with the SBIRT model? Okay, a few. But SBIRT is an acronym that we use in the United States when we're talking about behavior change. And much of the SBIRT work was initially done around addiction, both tobacco as well as other substances. And the acronym is for screening, brief intervention, and then referral to treatment. And, in the context of exercise, we're not really sending somebody to exercise treatment, right? We're connecting them with resources. But screening, in this case, is with the physical activity vital sign, which is asking people, how many days per week and minutes per day they're engaging in aerobic activity, what intensity level are they participating in, and are they providing or performing muscle strength training. Again, in this context, brief intervention is personalized advice to start, increase, or maintain or modify physical activity. It could be counseling using, again, evidence-based strategies like the trans-theoretical model to understand whether someone's in pre-contemplation, contemplation, preparation, action, or maintenance, using a 5A strategy to kind of further assess where they are with respect to their attitudes and experiences with exercise. And then, if it's appropriate, providing them with an exercise or physical activity prescription. So that's what we would put in that brief intervention column. And then, as I said, referral to treatment is less about treatment and certainly more about connecting people to resources. And we say it's connecting a patient to a person, which could be an exercise professional, a place, which could be a gym, it could be a structured exercise program, it could be a park, And then there's also other resources for people within the healthcare system. So it may be for somebody who has underlying cardiopulmonary disease that before they move into exercise, structured exercise, they need to undergo cardiac rehab. Or maybe somebody with musculoskeletal conditions needs to see a physical therapist before they actually move into an exercise program. For people who want to engage in physical activity as part of a weight program, it may be appropriate for them to see a registered dietitian. And we really advocate for the registered dietitians to also be talking to their patients about physical activity because it's a part of energy balance. And then, of course, there are community resources that people, are often active in within medical fitness. And in the United States, medical fitness is a gym or a fitness facility that's either co-located or connected to a healthcare system. Community fitness is probably most common, exercise professionals, and then a lot of people do self-directed exercise. And the majority of people in the United States who are meeting the aerobic physical activity guidelines do so through walking. And I don't know, I think that's probably true here in Greece too, because I've been doing a lot of walking, and right now I'm averaging about 14,000 steps a day walking around, so I think I'm doing all right. But, since the pandemic, there's been an acceleration in terms of virtual access to physical activity resources. And I, for one, have my virtual yoga teacher, Katie, every Friday morning. And I think that that's another way that people can have low cost, or in many cases, no cost access to high quality fitness resources. So think about this SBIRT model, as one that can kind of guide, how we address physical activity and exercise at the point of care with our patients. This actually can be done very quickly. I think it took me about 7 minutes to say it all, but actually at the point of care, it can go very quickly with a patient. Exercise medicine has also developed a lot of resources, both for physicians and healthcare professionals, as well as system leaders. And again, moving from left to right on this slide, on the left is the physical activity prescription that is available on the Exercise Medicine website. We have an entire healthcare provider's action guide, which really kind of lays out the steps for healthcare professionals and for administrators to actually implement kind of this exercise medicine solution, the SBIRT approach, into healthcare. And then Dr. Stoutenberg maintains a phenomenal resource list, which is also available on our website, and is a reference list of exercise medicine-related published research. This is something I think I'm most proud of in terms of our development, and this is the Prescription for Health series. And these are just some examples of the patient fact sheets that have been created that a healthcare provider could provide to a patient with how being active can help somebody with depression and anxiety, how being active can help somebody who's experiencing cognitive decline or has developed Alzheimer's disease, or how, again, being active can benefit somebody with Parkinson's disease. And these are created by the Exercise Medicine Clinical Practice Committee. They are regularly vetted and up to date. And to date, there are more than 30 medical conditions that are available for patients across the age spectrum. Okay, so I'm going to transition now and talk about my experience really integrating this work into a large healthcare system in the United States. I spent 13 years at Intermountain Healthcare, where I served as the Senior Medical Director for Wellness and Nutrition, and I was really the champion for integrating both the physical activity vital sign, but the entire exercise medicine solution into the healthcare system. So you can see the mountains in the background. I mean, it really is a lovely place to live. Please visit us next May. That's a patient tower. That's not where people, get well and stay well, right? That's where people go when they're sick. That's where people go when they have heart failure, when they have, an exacerbation of chronic obstructive pulmonary disease, when they have consequence of poor diabetes control. We call ourselves Intermountain Healthcare. But, let's face it, it's disease care, right? I can tell you there's very little health promotion that's taking place in the patient tower. We're taking care of people who are sick. So, that's the ethos, that's the culture, that's the financial engine of the healthcare system, is taking care of people who are sick. The doctors, they're used to pills, prescribing pills to make people well, right? It actually takes a fair amount of convincing. I mean, I'm preaching to the converted here, as the saying goes, right? I had to convince them that, exercise, was as powerful, or in many, if not most cases, even more powerful than the many pills they were prescribing. And, we have a saying that says, a man's health can be judged by which he takes two at a time, pills or stairs. So I had to do a lot of convincing, I had to help our leadership, understand that, less than a quarter of Utah adults were meeting the physical activity guidelines for Americans. Less than a quarter. That means 75%. 75 to 80% of Utahns were not meeting the physical activity guidelines for Americans. I had to show them that regardless of common health conditions like hypertension, COPD, diabetes, smoking, high BMIs, high cholesterol, that people who were more physically fit, people who were getting more physical activity, which of course is what drives, cardiorespiratory fitness, they had a lower risk of death across all those conditions. I shared with them the work of the late Dr. Steve Blair. You know, we wouldn't have exercise as medicine were it not for Dr. Blair's legendary work. But this is one of the studies he published back in 2009 in the British Journal of Sports Medicine, where he showed that, you know, if we could eliminate low cardiorespiratory fitness, you know, it would decrease all-cause deaths to a far greater extent than if we eliminated obesity, smoking, hypertension, high cholesterol, or diabetes. Now let that sink in for just a minute, because I think many of us in the room are involved in chronic disease prevention and management, right? That may even be the department in which we work. You know, but the truth is that based on, again, Dr. Blair's work, if we could eliminate low cardiorespiratory fitness, we would prevent more deaths than if we eliminated diabetes. And we've already heard, you know, from some of our distinguished guests, you know, that there's a mental health crisis worldwide. You know, it was making its way, you know, up in terms of prevalence prior to the pandemic, and it was all accelerated globally with the pandemic. And I find this research to be particularly impactful because this is actually asking patients about the effectiveness of various treatments for depression. And so on the y-axis is what they said was effective, and across the x-axis is, you know, they called it popularity, but it was the number of people who actually said this was the most effective treatment. And in that lower left-hand corner, you see a lot of commonly prescribed antidepressant medications or psychotropic medications, because lithium's on that. But, you know, what's in that upper right-hand corner? Most effective, most popular, exercise. And I could put up countless number of graphs, and it would show exactly the same thing. This graph looks almost exactly the same for anxiety as it does for depression. And last but not least, now, you know, I'm saying, okay, well, is it really healthcare's responsibility to be doing all this? Like, shouldn't this be public health, or shouldn't this be like the exercise people or the sports people? And I'm like, yeah, no, it's the healthcare people. And this is a commentary that was written by Drs. Tim Church and Steve Blair in the Journal of the American Medical Association. And I'll point out that it was published back in 2004, right? 21 years ago. We're still talking about the need to do this. This was published 21 years ago. And I'll read it to you. It says, the medical community needs to lead in communicating the importance of physical activity for health and weight maintenance. Just as weight is addressed in some manner at nearly every physician visit, so should attention be given to recommending the accumulation of 30 minutes a day of moderate intensity physical activity at least 5 days of the week. And I will tell you that that is really what inspired us to create, you know, a physical activity vital sign, to realize that we needed a prompt, something in the exam room, you know, that would bring into the discussion, you know, the role of physical activity in terms of promoting wellness and preventing and managing chronic disease. So I talked about all of that with my leadership. And I actually convinced a senior leader at Intermountain Healthcare, also known as a decision maker, to partner with me on this. And so he and I developed the physical activity vital sign at Intermountain Healthcare. We recruited one of my graduate students to come and do a postdoc at Intermountain Health, and he helped us actually do the validations. And then some of the other additional research that we have done over the years. And what you see on the slide there is what the physical activity vital sign looked like in our electronic health record. And what I want to point out is it had really good product placement. You know, and it turns out it all matters, right? Because if the clinician can't see it easily, they are not likely to use it. You gotta make it easy for them to do the right thing. So, you can see, systolic and diastolic blood pressure, heart rate, the other vital signs, and then right below that is the physical activity vital sign, asking minutes per day, times per week, the electronic health record, multiplied those to provide minutes per week. We had an intensity drop down of light, moderate, and vigorous. And then we had a box for physical activity consultation, meaning that the provider actually saw the vital sign, interpreted the vital sign, and then counseled the patient to start, increase, maintain, or modify their physical activity. So we could tell, I suppose they could have just clicked it, but we were hoping with integrity that people were seeing it, interpreting it, and then acting on it. So that was kind of how we created the vital sign at Intermountain Healthcare. But it took all of us. It just took all of us. I couldn't have done it alone without my colleagues. Well, in the States, we have this saying, maybe it's true here too, you can lead a horse to water, but you can't make him drink. And by that I mean, we created the physical activity vital sign. We validated the physical activity vital sign. We integrated it into the electronic health record, but that doesn't necessarily mean they'll use it. So how did we get them to drink? Well, I did what I'm doing now, lots of talking to anybody who would listen to me. I worked with another team where we nested this work, in some guidance around clinical best practice around lifestyle and weight management, which really provided clinicians and their teams both the why and the how, okay? So, because doctors don't like to do things if they don't understand the why, but they're busy. And, medicine is the ultimate team sport. We needed them to understand how to use all the members of their team to actually be successful, implementing the exercise as medicine solution. And of course, we had to prove to them that the physical activity vital sign was actually a valid measure of self-report of physical activity. And so that's where, teaming up with Dr. Trevor Ball, who was the postdoc, we published a number of papers, on the validation using, a variety of techniques, and published them in very high quality journals. And that's how we convinced the clinicians to use the physical activity vital sign. And of course, there has been ongoing research. And I heard, again, one of our distinguished guests, talk about how, regular physical activity, is one of the strategies to drive down healthcare costs. And healthcare is, just enormously expensive. And if we could decrease healthcare costs, then people have the resources to do other things with their limited money. So this was a study that we did looking at annual healthcare utilization and costs, by physical activity level. And we used it again to kind of convince the doctors that this was a good thing, as well as to convince our administrators to continue to support it. So let me just kind of walk you through this slide a little bit. So in the light blue at the bottom are people who we defined as sufficiently active, meaning they were getting 150 minutes or more of moderate to vigorous physical activity based on their self-reported physical activity vital sign. The medium blue are people we defined as insufficiently active. They were getting less than 150 minutes of self-reported moderate to vigorous physical activity. And then in the gray, are people that were defined as inactive. They reported 0 minutes per week of moderate to vigorous physical activity. Now, this is a very, very large data set. It was over 2 years. It has 1.2 million person years and just under 500,000 patients, adult patients. And really what I'm showing here is that, the people who were sufficiently active and they had less outpatient visits than those who were insufficiently active and inactive. They had half as many inpatient visits. And remember, I was telling you about that patient tower, where they take care of sick people, that's a financial engine for the institution, but it's really costly. That's where cost comes in, is where when people have to go into the hospital. So the people who were sufficiently active had half as many inpatient visits compared to those who were inactive. They had half as many emergency room visits. Their total hospital costs were half as much. So it was really very convincing to our leadership that they ought to be supporting initiatives that help people, get active and stay active, because it will lower costs. But we wanted more than the physical activity vital sign. And it was, over time that, we developed a great deal of trust with the organization. And we were able to do all of this at Intermountain over my 13-year tenure. And we specifically focused on efforts that would support healthcare providers and their team members through tools and good clinical workflow. And I know one of the later presentations in this session is focused on primary care workflow, so I'm looking forward to learning more about what happens here in Greece. And then we also had efforts that were focused on supporting patients and employees, by trying to overcome some of the barriers that people face when trying to engage in regular physical activity. So let's start with the healthcare providers and team members. Again, we integrated the physical activity vital sign into the electronic health record with good clinical workflow. We actually developed a pediatric physical activity vital sign and integrated that into the electronic health record, and I'm going to talk about that tomorrow. We developed good clinical workflow. We used the care process model that I showed you on lifestyle and weight management to support the care teams by defining the roles of that multidisciplinary team in order to, effectively and efficiently implement the exercise as medicine solution. We integrated referral pathways into the electronic health record. So again, it was easy for healthcare providers to actually refer a patient to physical therapy, to cardiac rehab, to a registered dietitian, into a medical fitness center, and even into community fitness, although that remains to be a challenge. We measured the outcomes that mattered for decision makers, such as cost. And then with respect to supporting patients and employees, we have private insurance in the United States. And so Intermountain's insurance company is Select Health, and they actually provide fitness benefit for their plan members. They provide no-cost access to fitness programming for older adults. So we really tried to eliminate cost as a barrier for people, particularly those who maybe have limited incomes. And our own employees, because if you don't, Intermountain's mission is to help people live the healthiest lives possible. And, we want everyone to be an example of that mission. And so our Intermountain employees have no cost access to on-site fitness facilities, which are available in every hospital and even many of our outpatient clinic buildings, as well as providing discounted access to community fitness facilities. And then we also encouraged our physicians and clinics to participate in a program called Walk with a Doc, which was created by David Sabgir. He's a preventive cardiologist in Ohio. And this is a program where people can invite their patients to meet with them and go for a walk. And we have hundreds and hundreds, thousands of patients who are doing Walk with a Doc with Intermountain physicians. So it's not enough to talk the talk, as the saying goes. You must walk the walk. And we also heard from one of our distinguished guests that culture eats strategy for lunch, and I couldn't agree more. And I thought the socio-ecologic model is a great way to kind of show what that culture is, because it's complex. It is. We had to influence the individual physicians, and healthcare providers. We had to create, a professional, even a social network, that of physicians who were all champions across a very large healthcare system. I needed to engage leadership. And the CEO of our healthcare system, when I was doing this work, he was an Ironman triathlete. I think he's done 7 Ironmans. So he was a pretty good, fitness role model and really helped to prioritize our work. And then, of course, there's the broader healthcare community prioritizing lifestyle. And although, I said that, Intermountain's, financial engine, was taking care of sick people, we still have the mission of helping people live the healthiest lives possible. And I've worked for a lot of organizations, in my professional career. That's the only mission statement I can ever remember. And at one point I thought, this is just it's so important to me, and it's so who I am as a person and as a professional. I should get a tattoo that says that. I never did, but I think that having a healthcare community that prioritized healthy lifestyle really helped a great deal when it came to really implementing exercise as medicine within the healthcare system. But Intermountain is not alone in this work, and there are lots of others in the U.S. and elsewhere who are doing a phenomenal job at this. As I mentioned, the whole Exercise is Medicine initiative was started by Dr. Bob Salas when he was president of the American College of Sports Medicine. He is at Kaiser Permanente, which is similar to Intermountain as an integrated delivery system based in California. And about the same time as we were developing the physical activity vital sign at Intermountain, he was developing the exercise vital sign at Kaiser and integrating that into the Epic electronic health record. And they have done some phenomenal work at Kaiser, really strong research. I think one of their most impactful studies was published in the last few years, where they demonstrated that high levels of self-reported physical activity was associated with fewer hospitalizations and deaths due to COVID-19. Now, the reason why I say it was so impactful is, we always think about, lifestyle behaviors, physical activity, healthy diet, tobacco use, excessive alcohol use, as being related to chronic disease, right? Diabetes, heart disease, hypertension. But this was a study showing that, physical activity was protecting people from, morbidity and mortality from an infectious disease. We could, again, have a completely separate talk about that in and of itself. And of course, most of those people who were dying in those early days, had established cardiometabolic disease, with obesity and hypertension and diabetes. And they had that pro-inflammatory state, which probably is what put them at risk for death from COVID-19. But it was a phenomenal, very impactful study to show that physical activity is not only good for chronic disease, but can actually help protect people's, health from infectious disease. I want to also acknowledge the work of Dr. Jennifer Trilk. She is at the University of South Carolina School of Medicine in Greenville and works with a healthcare system called Prisma Health. And Dr. Trilk has developed a 4-year medical school curriculum in exercise as medicine, and actually partnered with YMCA's, so community fitness, in that area, to provide structured exercise interventions, evidence-based structured exercise interventions, after referral from a healthcare provider. And if you want to learn more about what they're doing and the evidence they're creating, again, I would encourage you to talk with Dr. Stoutenberg, who, with Dr. Trilk, is launching a huge research project to look into this to an even greater extent. I want to talk a little bit more about other things that we're doing in the United States. There may be some parallels in Greece and in other countries that are represented here at this Congress. The National Physical Activity Plan was developed, probably 15 or so years ago. It is a very comprehensive framework that was designed to build a culture that supports active lifestyles and helps Americans meet the U.S. physical activity guidelines for Americans. And the work of the National Physical Activity Plan is shaped by 10 sector committees that you can see listed here. one of which is healthcare, and I have the pleasure of chairing the healthcare sector for the National Physical Activity Plan. And we have 4 strategies I thought I would share with you. The first is that healthcare systems should increase the priority of physical activity assessment, promotion, and counseling. That healthcare systems and professional societies should recognize physical inactivity and insufficient physical activity as treatable and preventable with profound health and cost implications. The third, that healthcare systems should partner with other sectors to promote access to evidence-based physical activity services that increase health equity. And then lastly, with a focus on education, that universities, postgraduate training programs, and professional societies should include basic physical activity education in the training of all healthcare. And we're doing pretty darn well in the healthcare sector. I actually presented our results, our 5-year results, at the ACSM annual meeting 2 years ago, because we have extensive tactics and measurable objectives to actually show that these strategies are in fact working. So I'm happy to share that with you. You can reach out to me afterwards. And I wanted to just call out the importance of partnering with other sectors because, as I mentioned, there are all of these different groups, that are working to do the same thing because we just need to have this is a complex problem, and we need to have this comprehensive effort. So one of the things that I have proposed as we move into the next iteration of the National Physical Activity Plan is that we're very intentional in having cross-sector strategies and collaborations. So between healthcare and schools, between healthcare and education, and healthcare and business and industry. So I think our next version of the plan can be even more effective and more impactful in the communities that we serve. In my introductory remarks, I called attention to the Physical Activity Alliance, of which Exercise is Medicine and the American College of Sports Medicine are partners. This is a coalition of organizations in the United States that has been effective, particularly in the policy arena. And I know we're really talking about both policy and best practices at this Congress. I've spent most of my time talking about best practices, but this is kind of some policy work that they're doing. And one of the first things they did was to help standardize language for the physical activity vital signs. So whether somebody is seen in Utah or Minnesota or California or New York, the physical activity, the self-reported physical activity questions that they get are all the same. And it can be documented in the electronic health record. So it can be used for public health surveillance, as well as for patient care. And so, the first question is, for an average week in the last 30 days, how many days per week did you engage in moderate to vigorous physical activity? And then it defines it. On those days, how many minutes? And then during the past month, how many times per week do you do physical activity or exercise to strengthen your muscles? Because of course, we're less interested in minutes, and the physical activity guidelines for Americans are at least doing strength training at least 2 times per week. The PAA has also led the development of an implementation guide. So this is informing healthcare systems, electronic health record manufacturers, how to actually implement this into their electronic health record and into their healthcare system. And then the PAA is also working to seek payer coverage for structured physical activity for certain conditions. Because I think this is a problem here in your areas as well, that seeing an exercise professional is often something that ends up being an out-of-pocket expense for people. And particularly for older adults who are on fixed incomes, that may be an expense they're not willing to bear, right? And yet we know, what is the number one thing people can do to prevent a fall, right? Is to exercise, especially strength training. And people who have low self-efficacy, very little experience with strength training, they're not going to do it on their own. It's too hard. They need to see an exercise professional in order to do so, and to do so effectively, and so on and so forth. So anyways, I fully support, we all fully support through Exercise is Medicine, the work and the leadership that's coming from the Physical Activity Alliance. And then there's Exercise is Medicine Active Aging. And again, you'll hear much more about this tomorrow. As I mentioned, we launched this in May of this year. And when I talk about the reason for this, it's because 12,000 people turn 65 every day in the US. We refer to it as the silver tsunami. And 17% of our population is 65 or older. And exercise is medicine definitely for falls, and the evidence around exercise for brain health is overwhelming, and heart health, of course, we've known that for decades. And yet, as you can see where those, the positive arrow sign there for the healthcare providers, that only 15% of men 65 and older, and just under 11% of women 65 and older are meeting the physical activity guidelines for Americans. We have a lot of work to do, to help them be successful, right? We want them to be successful with regular physical activity. And of course, another part of Exercise is Medicine Active Aging is, as I mentioned, connecting people to a credentialed, experienced health and fitness professional. So, in summary, Exercise is Medicine, is a global initiative, which is why I'm so thrilled to be here today. It was, launched 18 years ago. It's really around promoting physical activity as a standard of care in clinical care. The physical activity vital sign is a key first step. It's been very successfully integrated into health systems and into electronic health records. We have very strong evidence that regular physical activity reduces chronic disease risk, improves chronic disease management, improves quality of life, and lowers healthcare costs. But the integration of all of this work into healthcare requires clinician engagement, supportive workflow, referral pathways, coverage policies, and leadership. And that's what all of you are here, is, you are the leaders who are going to bring this to fruition in your healthcare systems. So, our next steps in the US and elsewhere, it starts with, standardizing the physical activity vital sign, expanding coverage and for structured physical activity programs that are provided by exercise professionals, strengthening healthcare provider training on physical activity, assessment, promotion, and referral, advancing equity, so that all people of all abilities have access to the physical activity resources that they need and they want in order to have an active life. And so, there's a real call to action here that we've heard from everybody who has stood here today, that we need to make physical activity a routine part of every patient's healthcare journey. And I wanted to just bring your attention to, that we know that physical inactivity and chronic disease is highly prevalent. It's highly prevalent, right? Only 25% of US adults meet the physical activity guidelines for Americans. And I think 60% of US adults have 2 or more chronic conditions, right? And yes, sometimes for those chronic conditions, particularly cardiometabolic and renal diseases, they need medical clearance, and as the clinicians, it's our responsibility to do that if that's necessary. But let's be clear. This is the greatest danger those people face. This is the greatest danger. We have to get people off the couch. So thank you very much.